Good afternoon, everyone. So after such an invigorating session on obesity, we move on to the next important and much awaited session, that is the KAICHI KIDA oral session. So this is an award session, and we have two prizes here of 1,000 US dollars each. So the first one would be for the best growth presentation, which is sponsored by the Human Growth Foundation, and the other would be for other endocrine and diabetes presentation, which is sponsored by Asia Pacific Pediatric Endocrine Society. So to judge this session, I would like to invite the judges. So they are requested to take their places at the round table on the left side. So Professor Noriyuki Namba, who is a professor and chairman, Division of Pediatrics and Perinatology, Faculty of Medicine, Tottori University, Japan. So Professor Namba, we would like to welcome you here. Good morning. Good afternoon. How are you doing, sir? Please. No. Take a place there, sir. So we'll have the presenters presenting their presentation from here. Okay. Then we have Professor Maria Craig, who is a professor from University of New South Wales, Australia, and also the serving president APPS. So Professor Maria, so we welcome you here. Then we have Professor Lee Youngjin, whose expertise we just witnessed a moment ago. So who is working in the University of Singapore. So Professor Lee Young Seng, we welcome you here, sir. Then we have Professor Junfeng Yu, who unfortunately could not join us in person. She'll be there online. So she is the President Children's Hospital at School of Medicine, China, and she is the President-elect for the year 2025-26. So Professor Junfeng Fu, we welcome you here. Then we have the other judge, Professor Sylvia E. Estrada, who is Division Chief, Pediatric Endocrinology and Metabolism at University of Philippines, and who also happens to be the Secretary of APPES. So we welcome you, Professor Sylvia, here. Okay. Then we have Professor Anju Seth, who is Director, Professor, and Head Departments of Pediatrics at Lady Hardinge Medical College, New Delhi. So we welcome you, ma'am, here. Okay. So we have the judges with us. So before we proceed with the presenter, so just please pay attention to an important instruction. So all of you have been allotted a time of 8 minutes each for your presentation, which are 3 minutes of question answer session. So there will be 3 bells. The first bell will ring at 6 minutes of your presentation, and the second bell will ring at about 30 seconds before the end of your presentation, and the last and the final bell would ring at 8 minutes. So please, and the session would freeze after 8 minutes. So please try to stick to the time given to you. And this will be followed by a question and answer session, and questions from the audience would be appreciated. But all of you are requested, please, to be brief, and there should not be any cross questioning. So I would like to invite Dr. Aradhna on stage to call upon the presenters.
So for the first paper presentation, I invite Dr. Amrutendu Anirudhan from India. The topic is screening for pancreatic autoantibodies among the first degree relatives of children and adolescents with type 1 diabetes. Hope you have understood the rules, and please.
Good morning all. I'm Dr. Amrutendu Anirudhan. I'm a junior resident in PGMR Chandigarh in the Department of Pediatrics. Today I'll be presenting my study titled Screening for Pancreatic Autoantibodies among the first degree relatives of children and adolescents with type 1 diabetes. In genetically predisposed individuals, environmental triggers precipitate the gradual destruction of pancreatic beta islet cells, resulting in the development of type 1 diabetes. Before the onset of clinical symptoms, there is an extended preclinical period which can be categorized into 2 different stages. Stage 1 with multiple antibody positivity and normoglycemia, and stage 2 with multiple antibody positivity and dysglycemia. This is followed by the onset of clinical symptoms in stage 3, by the time which 80% of the pancreatic beta islet cells are already destroyed. This preclinical period offers an opportune window for interventions that can prevent or halt the prevent or halt over diabetes by slowing down or halting the progression of beta cell loss. In a recent trial, teplizumab, an anti-CD3 monoclonal antibody, was demonstrated to delay the progression from stage 2 to stage 3 by a median of 2 years. And has been approved by US FDA as the first ever disease-modifying therapy for type 1 diabetes. So we planned the study. Aiming to assess the prevalence of preclinical type 1 diabetes among the first-degree relatives of children and adolescents attending pediatric diabetic services at PGMR Chandigarh. This was a single-center cross-sectional observational study in which we enrolled 321 first-degree relatives who were non-diabetic and between the ages of 6 months to 40 years. We performed ELISA screening for 3 pancreatic autoantibodies, anti-glutamic acid decarboxylase 65, insulin-associated autoantibody, and insulin autoantibody. Individuals who were positive for 2 or more autoantibodies underwent oral glucose tolerance test, fasting C-peptide levels, HbA1c, thyroid function test with anti-thyroid peroxidase levels, and tissue transglutaminase IgA antibody levels. In total, 321 first-degree relatives from 176 families were screened, including 263 parents and 58 siblings. The study population comprised of 111 fathers, 152 mothers, 31 sisters, and 27 brothers of 176 index children with type 1 diabetes. The median age of parents enrolled was 32 years. The median age of siblings enrolled was 7.5 years. All the siblings were less than 20 years of age, with the youngest sibling enrolled was having 1.5 years of age. This is the age and gender distribution of the study population. Maximum number of individuals were enrolled in the 36 to 40 years age group. Around 18% of the population was less than 18 years of age. Below 20 years of age, the population was evenly split between males and females. Above 20 years, predominantly females were enrolled. 78 individuals were positive for at least one antibody, giving a prevalence of 24.29% for beta cell autoimmunity in our study population. Compared to pre-existing data, this is slightly higher. In pre-existing data, a range of 3 to 23% prevalence was given. So we had a prevalence of 24.29% for beta cell autoimmunity in our study population. The highest antibody proportion was seen in 16 to 20 years age group. The proportion of antibodies was almost similar in parents and siblings group. This was in contrast to the previous studies, which had indicated that a significantly high proportion is to be seen in siblings compared to parents. 71 individuals of the study were positive for one antibody. This included 58 parents and 13 siblings. 6 parents and 2 siblings were positive for GAD65. 26 parents and 3 siblings were positive for IAA antibody. 26 parents and 8 siblings were positive for IA2A antibody. 7 individuals were positive for 2 antibodies, fulfilling the criteria for preclinical type 1 diabetes. This comprised of 6 parents and 1 sibling. 5 of the 6 parents were more than 35 years old. The sibling was a 16-year-old girl. These 7 individuals who were in preclinical stage of type 1 diabetes were subjected to tests for glycemic control, and 5 subjects were found to have dysglycemia. 2 of them had impaired fasting glucose levels, 2 of them had impaired postprandial glucose levels, and 1 had impaired range of HbA1c according to ISPAT 2022 guidelines. So these 5 subjects were placed in stage 2 of type 1 diabetes. The other 2 subjects who had normoglycemia were placed in stage 1 type 1 diabetes. So summing up, the prevalence of preclinical type 1 diabetes in our study population was 2.18%, with 1.72% being positive in the sibling group and 2.28% of the parents being positive in the parents group. The prevalence of the stage-wise prevalence was 0.62% prevalence in stage 1 and 1.55% prevalence in stage 2. None of the individuals were screened positive for 3 antibodies, and we could not find any statistically significant correlation between age, gender, or relationship to the index. These are the proportions of individual autoantibodies. While the prevalence of GAD65 was comparable to previously existing data, we noted an increased prevalence of IAA and IA2 antibodies in the study population overall, as well as in the parents and siblings group separately as well. This is the detailed workup of first-degree relatives with preclinical type 1 diabetes we had identified. We had also screened them for celiac disease and autoimmune hypothyroidism. One subject was found positive for subclinical autoimmune hypothyroidism. Two of the subjects had shown positive celiac serology, and one of them had exhibited endoscopic gut mucosal changes on upper G endoscopy. To the best of our knowledge, this is the first study that has screened first-degree relatives in the Indian population for pre-symptomatic type 1 diabetes. However, due to limited sample size, particularly in the younger age group, caution is needed in generalization of these findings. Also, inclusion of HLA genotyping would have improved the quality of our data and enabled us for risk stratification. The individuals who were positive, found to be high risk in our study are potential candidates for future preventive trials. By identifying these individuals who are at elevated risk, we can do optimal resource allocation, which would ensure the success of these preventive trials. Also, our studies are supporting the need for a proactive and targeted screening for individuals at high risk for familial context. But the practical feasibility of starting to screen the first-degree relatives in Indian settings is limited because of cost and logistics issues. To conclude, there's a high prevalence of beta cell autoimmunity and preclinical type 1 diabetes in our population, which underscores the need for a targeted screening in this high-risk population so as to identify the high-risk individuals. However, the practical feasibility of this in our settings is limited, at least until cost-effective investigations and disease-modifying therapies become available. So at present, smaller studies in research settings to identify high-risk individuals that can be enrolled in these preventive trials will form the next step for achieving the broader goal of universal screening and thereby type 1 diabetes prevention. Thank you.
Now we invite questions from the audience.
Thank you for your nice paper. May I? Thank you for your nice paper. Would you like to highlight the assay for the antibodies? Because I think it all depends on the, how robust is the assay for your 3 antibodies. So what was the source of the antibody kits? Were they in-house assay or commercial assay?
No, ma'am. We had purchased standard commercial kits and had performed ELISA for all the 321 individuals.
So you need to be a little bit more specific about the assay, though, because there's quite a number of different assays globally. And we heard from the wonderful talk from Professor Cooper yesterday. Can you tell us a bit more about when you say it's a standard assay? Was it a RSA or was it a radioimmunoassay?
Ma'am, it was a standard ELISA.
Okay, thank you.
Amrithendu, I'd like to ask you a question. You have those 7 individuals who already have dysglycemia. How do you propose to follow them up? 1. And what do you propose to do with the individuals who have 1 antibody?
Thank you for the question, ma'am. The individuals who were positive for 2 antibodies, so we are planning to monitor them for the development of clinical type 1 diabetes. Recently, recommendations had come up which had suggested 3 monthly follow-up and monitoring for these patients to follow their glycemic progression of their dysglycemia. As for the individuals with single antibody positivity, the 13 children who had single antibody, they should definitely be followed up for development of subsequent antibodies. But in overall also they should be monitored perhaps at a lesser frequency than the ones in with multiple antibodies. But because around 3 to 5 years, maybe we should screen them for antibodies because later development of antibodies has also been documented. And we should also screen them for other autoimmune diseases. Like we had screened for celiac disease and autoimmune hypothyroidism in our 7 individuals who were having preclinical type 1 diabetes. But we should be screening for the individuals with single antibody also because they could also be having a generalized autoimmunity with multiple systems getting involved.
Okay, thank you.
Thank you.
Thank you. So, for the next presentation, I invite Dr. Nimisha Dansh from India. The topic is bone health, body composition, and dynamic muscle function in Indian children born small for gestational age, a case control study. Dr. Nimisha?
Good morning, everyone. I'm Dr. Nimisha Dange from Pune, India. I will be presenting a case control study titled Bone Health, Body Composition, and Dynamic Muscle Function in Indian Children Born SGA. Early life origins of later health and disease with metabolic adversity is well known. SGA children may have poor intrauterine growth, causing suboptimal bone mass accretion during infancy, leading to compromised musculoskeletal health in prepubertal years. Previously, it was reported that bone mineral density was on average low normal in children born SGA. SGA children, in spite of catch up in height as well as weight, may not adequately catch up in bone geometry and muscle function. Birth size significantly influences body composition and bone health. Muscle mass and functional capacity can be altered independently. Hence, body composition, bone health, and dynamic muscle function are interrelated. However, there is a paucity of research exploring bone geometry, muscular health, and bone density in Indian SGA children. Therefore, we hypothesized that children born SGA have suboptimal bone mass and bone geometry more pronounced in those who fail to catch up. Body composition influences skeletal health and muscle function. Taken together, the objectives of the current study are to evaluate bone health of 8 to 11-year-old children born SGA versus AGA using DEXA and PQCT, to study association of bone health, body composition, and dynamic muscle function. This was an observational cross-sectional study. Children enrolled in a longitudinal cohort study were invited to participate in this study. Healthy siblings who were born appropriate for gestational age were enrolled as controls. Children in the age group 8 to 11-year-old born at term delivery with available birth weight and birth length records were included. The final analysis was performed on 126 cases and 126 controls. Anthropometry and clinical history were noted. Bone health was assessed using DEXA and PQCT. Dynamic muscle function was evaluated using jumping mechanography. Bone age was evaluated using left hand and wrist X-ray. The DEXA was performed at lumbar spine and total body. DEXA is a two-dimensional measurement of a three-dimensional structure and hence size adjustment is required. Aerial bone mineral density was calculated. Height adjustment is crucial during interpretation of the results. PQCT was performed at the radius of non-dominant forearm. From the distal end of the radial metaphysis at the 4% site, trabecular volumetric bone mineral density, and at 66% site, cortical density, periosteal circumference, endosteal circumference, and stress strain index were evaluated. Higher the stress strain index, higher the fracture load, meaning low is the fracture risk. On jumping mechanography, single two-leg jumps were performed to assess maximum relative power, and multiple one-legged hopping were performed to assess maximum relative force. The mean age of the study population was around 9.5 years, with average birth weight in AGA group 3 kilos and average birth weight in SGA group around 1.9 kilo. AGA children were significantly taller and heavier. SGA children, however, were short for mid-parental height and with advanced bone age. Aerial bone density at lumbar spine was similar in both the groups. SGA group was further subdivided with catch-up growth and without catch-up growth, and the lumbar spine density was similar in both groups. However, aerial bone density at total body was significantly lower in SGA children who failed to catch up. On PQCT assessment, stress strain index, trabecular volumetric density, periosteal circumference were lower in SGA, especially in those who failed to catch up. Fat mass index and lean mass index were calculated using fat mass divided by height in meter square and lean mass divided by height in meter square formulas respectively. Fat mass as well as lean mass were significantly higher in AGA boys. For further analysis, lean mass index were divided into 3 equal groups, tertiles. The graph here represents the relationship of lean mass index with bone health. The red bars represent children in the lowest tertile of the lean mass index. Poor aerial bone density was noted with poor lean mass significantly in AGA children than SGA because of stronger association of lean mass and bone density in AGA group in comparison with SGA. The similar results were seen in the girls. This implies that skeletal health is driven by muscular health in both boys and girls. Stress strain index, trabecular density, periosteal circumference were higher in AGA children as compared to SGA, both boys and girls. Maximum relative force and maximum relative power were unaffected by muscle mass in AGA as well as SGA, boys and girls. This implies that muscle function is independent of lean muscle mass. To summarize, children born SGA had lower DEXA-derived aerial bone density at total body compared to controls. Volumetric densities and stress strain index were suboptimal in SGA children, and this difference was highlighted more in SGA, especially in those who failed to catch up. Lean mass positively influences both aerial and volumetric bone density. The ability of muscles to function effectively is not directly related to the amount of lean mass. This was the first Indian study to evaluate bone health in children born SGA. We performed PQCT assessments which are size independent and provide clearer results than DEXA alone. Dynamic muscle function was evaluated for the first time in Indian children. Role of genetic, hereditary, and environmental factors need to be evaluated. Fracture assessment is crucial while evaluation of the bone health. More longitudinal and multicentric studies, including older age group, are required to generalize the findings. To conclude, attention should be given to skeletal health while evaluating children born SGA, especially who fail to catch up. Optimizing body composition is key to improving bone density and overall skeletal health. Muscular strength and performance are not dictated by body composition. Therefore, need-based DEXA assessment will add relevant information to clinical assessment of SGA children. Thank you so much.
Thank you. Thank you so much. That was a wonderful presentation. You've chosen 8 to 11-year-olds for your study. So, and particularly SGA and boys could go into puberty later and SGA girls could start puberty. Could your difference be narrowed because of the pubertal status, and have you controlled for it in your study?
Here we could not assess the sexual maturity rating because this study was performed on children from village, and obtaining consent for the Tanner staging was difficult. Hence, as a proxy, we evaluated bone age, though it is not reliable in SGA children, but for the onset of puberty, I think it is reliable. In the interest of time, we could not show the difference as per the or the adjustment for the bone age for the bone density. But yes, children who with significantly advanced bone age had a similar bone density as that of AGA group.
Okay. So Nimisha, my question was that how did you define SGA in this cohort? Was it based on weight catch-up, or sorry, how did you define catch-up? Weight or height?
Catch-up was defined as per the height, and because this was a cross-sectional study, the previous readings were not available, so the catch-up in terms of mid-parental height was taken into consideration. Those who were short for the mid-parental height were considered as failure to catch up in height.
So, despite adjustment for height, those who had not caught up had lower bone mineral density, despite adjustment in height?
Yes.
Okay. And the other question, if I may just be quickly permitted, like this jumping mechanography, what exactly was the technique? So, what exactly do you measure in that?
The maximum relative force and maximum relative power are assessed on dynamic muscle function.
So the person jumps on something which measures these things.
Yes.
It's
so
a very
the on-
standardized test.
Yes, and the reference data is available for that, and we have recently published the Indian reference norms for pediatric dynamic muscle function.
Thank you.
Thank you. I'll try and be quick. Just a couple of quick questions. Firstly, remind us how you defined SGA. Which criteria did you use? Did you use birth weight and birth length less than -2 SDs, or which criteria did you use? That's the first question. Second question is just following up from what Ahila had said. There's a high risk that a significant portion, particularly of your girls in the SGA group, will be in puberty, and that's going to change their muscle mass, it's going to change their fat mass, their bone density, and their growth. Did you, and you said you didn't have pubertal staging, did you think of looking at the data and stratifying into age groups? Okay.
I will answer your first question. I think I partly understood the second question. So, for the first question, children with SGA were defined with either birth weight or birth length below -2 standard deviation. We have taken into consideration those children who were born at full term, and therefore they were defined using WHO growth standards criteria at birth. About the second question, I think it was the puberty in SGA girls, and as I mentioned earlier, the bone age was taken as the proxy for onset of puberty. And in the interest of time, I could not show you the bone age adjustment, but they were the bone density was similar as that of SGA group. Thank you very much.
Thank you, Dr. Nimisha. So now the third presentation is on bone age assessment using automated methods for Grulich and Pyle method using segmental transfer learned to Indian children. For this, I invite Dr. Chirantap Oza from India.
So, good morning, everyone. My name is Dr. Chirantap Oza, and I'm a pediatric endocrinologist from Ahmedabad, India. And I would like to thank the organizing committee and scientific committee for giving me this opportunity to present our work on bone age assessment by artificial intelligence for Grulich and Pyle Atlas method using the process of transfer learning in Indian children. This study was conducted at Hirabai Kowasji Jahangir Medical Research Institute, Pune, in collaboration with Indian Institute of Science Education and Research, Pune. So as pediatric endocrinologists, we know that bone age is important because it's a marker of physiological skeletal maturation, and it correlates better with the bone mineral mass, height velocity, and muscle mass as compared to the chronological age. It is an important tool for height prediction, particularly in children with disorders of growth and puberty. Some of our group's research in the field of bone age includes showing that a tight relationship exists between height age, bone age, and chronological age in healthy Indian children, with a significant role of nutritional status and pubertal onset in causing the variation in same. We have also designed a simplified new method of bone age estimation using 3 bones of hand, namely the radius, hemate, and terminal phalanx of middle finger epiphysis, to evaluate bone age in office practice. We have also standardized the weightages assigned to different segments of the hand X-ray, namely the distal end of radius and ulna, the carpals, and the short bones of hand, to assess bone age by Grulich and Pyle method in Indian children. But while these studies, there were a few limitations of traditional methods of bone age assessment that included that they were very time consuming, they did not account for secular trend and ethnic variation, and had significant intra and inter-observer variation. To overcome these, artificial intelligence and machine learning is the way forward. And the most commonest method that is employed is the deep learning using a convolutional neural network. The CNN is already being used in medical field to detect the patterns of interstitial lung diseases on CT scan imaging, or to segment the vascular network of human eye on fundus photographs. As we know, there are some artificial intelligence tools available for bone age assessment. The oldest and commonest that we might know is the Bone Expert, that was launched in year 2008, that was trained on a data set of 1,678 X-rays. Various other CNN networks that are used for the same are shown in this table. So, in our work in the field of use of artificial intelligence, we found that when we used Bone Expert to assess bone age of healthy Indian children as well as Indian children with type 1 diabetes, a backward compatibility had to be established by assigning around 50% of weightage to the carpal bones in the prepubertal children. While using other artificial intelligence tools like the Bone Health Index, again, a correction for ethnicity was needed. And the reason for that we thought was that these softwares are trained on either European or American data set, and that could be a major research gap. So we conducted this study with the objective to create an artificial intelligence-based model for assessment of bone age by Grulich and Pyle method using a convolutional neural network. To fine-tune this model by training on bone age X-rays of Indian children to improve its accuracy, and to assess the validity of software-generated ratings by comparing them with manual reference ratings. So the software was developed in 4 versions. The first version that was trained on the Radiological Society of North America dataset and validated on the same. When the same was used for Indian X-rays, we did found that there was some discrepancy. So at present, we present the results of the third version, wherein by transfer learning, the software was exposed to Indian ethnicity X-rays. The methodology has been published in the paper that is shown on the screen. But to say in brief, the image segmentation was achieved using a convolutional neural network with UNet architecture and was trained to obtain 3 segments of the full hand X-ray. The transfer learning process was achieved by using over 2,000 X-rays of Indian children aged 0 to 18 years. The validation dataset for the first version was the RSNA validation dataset, but for the second and third version, we used an Indian validation dataset that included hand X-rays of 169 boys and 179 girls. The manual reference rating was calculated by 2 experienced pediatric endocrinologists by Grulich and Pyle method, and the automated rating was obtained by the software. To understand the process of transfer learning, it was achieved using a DenseNet 161 model architecture and transfer learning. So the number 161 says the number of convolutions that the image goes through in the process of processing in the shape of a U. So the first image, once uploaded, it is segmented into areas of interest, and then a bone age is assigned to them, and the final answer is received. As we can see on the image, the baseline model was trained on all the layers on the RSNA dataset, but the transfer learned model, the last layer of baseline model, was trained on the Indian dataset from Pune children. So this is the correlogram and the Bland-Altman plot for the bone age prediction, and we found that the correlation coefficient was around 0.9 to 0.92, and the average standard deviation was around 0.7 years between the automated and the reference rating. The mean absolute deviation for the present, the third version of the software, is 6.7 to 7.3 months. Higher mean absolute deviation is because of variation in the carpal segment development, because the network is not able to capture a meaningful pattern of the carpal bone development. So as we can see, the delay in carpal bone age for Indian boys and girls is around minus 0.66 years and minus 1.34 years respectively. These validation correlograms also show that the carpal segment had the poorest correlation coefficient and the highest standard deviation. So this is the first study wherein we have used CNN to automate the process of predicting bone age for Indian children. And the model prediction shows high correlation with reference GP ratings at a population level after transfer learning with Indian X-rays. The limitations are that the mean absolute deviation reported for carpal segment is still higher due to probably ethnic variation in onset of puberty as compared to the reference GP. We aim to reduce the mean absolute deviation in the carpal segment and to train the software for rating bone age by the Tanner-Whitehouse method. This is how the software functions. So first we can upload any image. The image for bone age X-ray should be in JPG or PNG version, format or a DICOM format. And once we choose the gender, the software will rate the bone age for the full hand as well as individually for the 3 segments of hand and give us an average of 3 segments. In conclusion, we thus present a new artificial intelligence tool for bone age prediction that was trained on the RSNA X-rays but fine-tuned by training on X-rays of Indian children by the process of transfer learning. And the mean absolute deviation of full hand bone age prediction is comparable to other AI tools available at present, as well as to the reference rating. On behalf of the entire team of Digibone, I would like to thank you all for your kind attention. Thank you.
Thank you. Can I have a question for you?
Yes.
Yes. Yeah. Query. It's a very interesting study. So, as recently, bone age evaluation system by AI has been widely used. Why this time you are using GP method instead of the TW3 method? Because GP method is a little bit limited. Sorry. So why you are using GP method instead of TW3? Is there any priority by using GP method compared to TW3? Because TW3 is more accurate, and there is more than 20 settlements that can be evaluated by AI, and it is also widely applied and used. And where is priority for your study? This is the first question. The second question, as I take a look at your study, for the validation setting, you are only use 169 boys and 179 girls for the validation setting. To me, I think it's too small. What do you think about this database? Okay, thank you.
Thank you so much for your question. To answer, the Radiological Society of North America data said that the RSNA challenge was performed was for the Grulich and Pyle method. So we first have trained the software for the GP method, probably because it is a more common and widely used method, and also because the RSNA challenge was on that. And yes, we do agree that Tanner Whitehouse, being an analytical method, is more accurate according to some studies. So that is the scope of future research. In the fourth version, we do plan to present bone ages using the Tanner Whitehouse method. To answer your second question, for the RSNA dataset, because they use 12,600 X-rays for training, and approximately 15% of those, that is 1,400, were used for the validation. Similarly, because we used around 2,000 X-rays for training by transfer learning, we used roughly 50% of those, so around 350 X-rays for the validation dataset. We could not give statistical significance based on the sample size because no prior results for the similar kind of study are available. But yes, a bigger data set, if and when available, we probably would be using the same for validation as well.
Just a quick couple of very interesting study and just a couple of points. One is with regards to the rotation and the exposure, which is a major problem. Do you pre-treat those X-rays before it is gone put into the network? That is one. And second is that with our experience in the segmental one, we do realize definitely it's that the phalanges which are the most important, and we give least rating to the radius ulna or the carpals. We have excluded it all. So do you think excluding the carpals would be a better option here?
The oldest other studies that have performed have suggested that ignoring carpals altogether might not be the precise way to do it. So what we plan is we give a full hand X-ray using all the bones of hand, and we also give individual segment ratings. So it depends on the person who's using it on how much weightage to be given to carpals, because it is affected by the nutritional status, by the levels of the sex steroids, like the onset of puberty and all. So yes, that was the reason that the mean absolute deviation was a little bit higher. As far as pre-processing is concerned, no, the software has learned to identify the noise, and it only takes into account the area of interest, that is to give the bone age assessment. So we don't need any pre-processing. Thank you so much. Thank you.
Thank you, Dr. Chiranta. For the next presentation, I invite Dr. Dhwani from India on development and validation of DSD Interpreter, a mobile application-based tool for point-of-care evaluation of children with atypical genitalia. Over to you.
Thank you, ma'am. Good morning, everybody, and thank you, Team APIS and SPA, for giving me an opportunity to present my research at this eminent platform. Disorders of sexual development are common, with an incidence of 1 in 5,000 live births. They are a common medical emergency in pediatric endocrine practice. However, for most of these children, the first point of contact are often pediatricians and neonatologists who have received limited training in dealing with these children during their formative years. Often, we've seen that a huge battery of investigations is prescribed, which are often misinterpreted, leading to delayed and messed up diagnosis in these children. This clinical scenario causes significant medical, financial, and psychosocial distress to the parents and family. To highlight this issue, let me show you two cases encountered in our clinical practice. The first was a neonate assigned male gender at birth. Parental concerns regarding bilateral cryptorchidism and a small phallic size were disregarded. At 3 weeks, this baby presented in shock. Workup revealed salt wasting, high 17 OHP levels, and ultrasound showed the presence of Müllerian structures. Lack of awareness in this case pushed the child to a near death experience, increased the medical expenditure of the parents, and what came next completely shook them, having to redecide the gender of their baby. The second was another neonate with isolated micropenis extensively worked up for DSD, mislabeled as 21 hydroxylase, who went on to receive steroids in the form of hydrocortisone and fludrocortisone. At presentation to us at 4 months of age, the baby was Cushingoid and had developed hypokalemia. Careful evaluation, clinical and lab-wise, revealed the diagnosis of a multiple pituitary hormone deficiency here. What these two cases highlight are that children with atypical genitalia are often missed or missed in the clinical setting. To prevent and overcome this, we wanted to develop a point of care tool that was easy to use, validated, and accessible to all, allowing evaluation of children with atypical genitalia. We had previously developed multiple mobile applications allowing guidance in children with pediatric endocrine disorders, and to take our venture one step forward, we developed the DSD interpreter, primarily targeting the pediatricians and neonatologists to allow early diagnosis and referral of children with genital ambiguity. The app algorithm is based on Global Disorders of Sex Development and the UK Society Guidance Guidelines, which have both been adapted to an Indian scenario, laying key emphasis on clinical parameters, allowing minimal investigations to make it resource friendly and giving rapid results. To further elaborate, in a hierarchical manner, the app first looks at presence or absence of palpable gonads and Müllerian structures, based on which it further guides you to look at various clinical or lab parameters. Other clinical parameters that it looks at are maternal virilization and genital asymmetry. The key lab investigations that it requires are serum electrolytes, 17 OHP, testosterone, DHT, and AMH levels, based on which it gives the diagnosis of a wide variety of DSDs that one may encounter in clinical practice. To demonstrate how it works, had the neonatologist to whom the initial child had presented used our application, the rationale of the app would have guided them that a child with bilateral cryptorchidism requires evaluation for DSD. Using the application, they would have known that no palpable gonads requires investigation for Müllerian structures, which would have shown yes here. Then go for maternal virilization history, which was negative in this scenario, followed by the app guiding them to go for 17 OHP and electrolyte levels. Based on these input, the app gives you the likely diagnosis. It prompts you to start hydrocortisone and fludrocortisone in this child, monitor 17 OHP and electrolytes at follow-up, and gives the guidance on the gender of rearing. In the second case, using the app would have prevented extensive workup in a child with isolated micropenis. The app was validated in 55 children with atypical genitalia who came to our clinic, of which 6 were DSD mimics. There were 21 with XX, 27 with XY, and 1 with overtesticular DSD. Validation was done by 2 experts, a pediatrician, a neonatologist, and a pediatric trainee, who were all given clinical scenario of these 55 children in the form of a Google questionnaire, along with picture wherever available. The first step required them to plan initial workup, and 1 mark was awarded for correctly planning it. When they answered the first step correctly, the lab reports were shown to them, based on which they were asked to make a clinical diagnosis. The diagnosis made by these doctors and the DSD interpreter were validated against the final clinical diagnosis in these children. The results showed a high degree of concordance of the DSD interpreter. It performed at par with the experts and significantly better than the primary care doctors at the level of initial clinical impression as well as the final clinical diagnosis. The extent of discordance, if I were to elaborate it, the application showed 0 instances of discordance at the level of classifying DSDs and missing adrenal forms. Similarly, there were 0 instances wherein the app prescribed extra investigations. The major discordance at the level of non-experts included misclassification, misdiagnosis, and missing of salt-wasting forms of DSD. Whereas at the level of expert, the major discordance included overworkup. There were 4 instances of minor discordance seen by the DSD interpreter, of which one was a case of 5-alpha reductase, wherein the app made diagnosis of PAIS, and there were 3 cases of isolated steroidogenic defect, where further workup revealed Smith-Lemli-Opitz syndrome, XX male, and DHX37 mutation. So the expected benefits of using the application at the level of non-experts are early identification and referral, stepwise evaluation and rightful interpretation of the results, timely initiation of steroid, and a guidance on the gender of rearing. At the level of experts, the app is expected to reduce prescription of cost-intensive investigations. The major limitation of the study remains that it was presented as a Google form questionnaire, which cannot replace evaluating a child in your busy OPD clinical practice. Moreover, incorrect first step forbade them from going to diagnosis. So with the aim that we had started out, I believe we were able to develop an easy-to-use, accessible to all, validated tool for guidance in children with atypical genitalia that was not only cost-effective, but provided instantaneous results. This project would not have been successful without the mentorship of Dr. Anurag Bajpai, Mr. Shalabh Dikshit, who helped us with the app development, my colleagues, Dr. Vibha and Dr. Alappan, and the entire team of Regency CDR. Our mobile application, Mediclasses Endocrinology, is available on both Google and iOS platforms. We would love for you to check it out and give us a feedback. Thank you.
So can I ask a question as one of the judges? That was a lovely presentation. We all know the world of apps come and go, and clearly you demonstrated there was some efficacy. We all were a bit worried about the 10% of the junior trainees. My question, and I know we're short on time, is how are you going to implement this? Because it's one thing to do this research, but how are you actually going to improve that 10% of junior doctors to 100%?
Yes. So, of course, using the application would also require basic understanding of how to examine for gonads and Mullerian structures. So, a basic medical knowledge definitely needs to be increased for the trainee doctors. There's also an approach pathway that I could not show because of lack of time. The approach pathway further adds to the value of the DSD interpreter app, making diagnosis even more powerful in this scenario.
What tool you use to identify Mullerian structure in a child of 1 year's age? Since ultrasound, people do not identify it easily.
Thank you, sir. So this is mainly targeted to evaluate in the neonatal period itself. So our aim was to not miss any child with atypical genitalia, and all of our children were again neonates picked up within the first 2 months of life, wherein we were able to get Mullerian structures on ultrasound.
Oh, thank you.
Thank you, sir.
Hi, that was a lovely talk. Thank you. 2 short questions, hopefully. Your gold standard for your validation, where you had 100% for your... How did you define your gold standard?
Gold standard was the final clinical diagnosis. So out of the 49 children with DSDs that we had in our cohort, 24 did have a genetic diagnosis, of which 19 had a proven diagnosis and 5 unfortunately did not show any abnormality on genetic testing. The others were based on clinical information, wherein the clinical course of the child decided the final diagnosis for the rest of them.
Okay, so it's previous. Okay. The other question I had was on this. You said it can help with deciding the gender of rearing. How on earth can you justify that? Because it's such a hard thing, and where do you get the follow-up data for that?
Yes. So the app only does the part of guiding the gender of rearing. Finally, choosing what the child should be reared as requires counseling, requires sitting down with the parents, the family, and but at least giving counseling the right way of gender of rearing with giving them an option that may preserve fertility in the long term is something that is required at birth and is often missed out in the community setting in our experience. So that is what we set out for. Thank you.
Thank you, Dr. Dwani. For the last presentation, I invite Dr. Sukanya Priyadarshini from India. And the topic is metformin for reducing hepatic fat fraction in overweight and obese adolescents with non-alcoholic fatty liver disease, results of a randomized double-blinded placebo-controlled trial.
Good afternoon, everyone. I am Dr. Sukanya from AIIMS New Delhi, and I shall be presenting a study on metformin for reducing hepatic fat fraction in adolescents with non-alcoholic fatty liver disease, results of a randomized double-blinded placebo-controlled trial. This study was funded by the Indian Council of Medical Research. So as we all know, non-alcoholic fatty liver disease or metabolic associated steatohepatitis is defined as fat content exceeding 5% of liver weight in the absence of excessive alcohol intake or other causes of steatosis. The prevalence of NAFLD or MASH is to the tune of 60% in Indian adolescents with overweight and obesity, and its spectrum ranges from steatosis to steatohepatitis all the way to liver fibrosis. Children with NAFLD have a 13.6 times higher risk of death and liver transplantation than age and sex-matched controls. At present, there is no pharmacological intervention which is approved for the management of non-alcoholic fatty liver disease in children, and lifestyle interventions remain the mainstay of management. Metformin is a promising pharmacologic therapy primarily because of its effect on insulin resistance and reduction in hepatic lipogenesis. There's unequivocal evidence in its favor in adults with MASH and type 2 diabetes. However, the evidence is conflicting in adults with isolated MASH. Data in children are scant, with chief emphasis on reductions in BMI, HOMA-IR, serum insulin, which are primarily surrogate markers, conflicting reports on steatosis, and absence of high-quality evidence. So we undertook this study with the aim to assess whether metformin given in conjunction with a rigorous diet and lifestyle intervention is superior to a rigorous diet and lifestyle intervention alone in Indian overweight and obese adolescents with non-alcoholic fatty liver disease. The primary objective was in children aged 10 to 18 years with overweight or obesity and non-alcoholic fatty liver disease to compare the proportion on metformin and rigorous diet and lifestyle with the proportion of children on rigorous diet and lifestyle alone in achieving a greater than 40% reduction in hepatic fat fraction on MRI from baseline after 24 weeks of intervention. The secondary objectives included comparison of effects of intervention and control in study participants on various parameters such as body mass index, waist circumference, body fat percentage, glycated hemoglobin, lipid profile, blood pressure, liver enzymes, and liver controlled attenuation parameter, which is a measure of the fat content of liver. The study was conducted at AIIMS Delhi. It was a randomized double-blinded placebo-controlled trial that lasted 4 years from 2018 to 2022. Because it was a placebo-controlled trial, both the drug and the placebo, which was identical in its appearance, were procured from Solan in Himachal Pradesh. Patient eligibility included children attending pediatrics OPD aged 10 to 18 years who were either overweight or obese, residents of NCR or outside of NCR, but willing to follow up regularly for 6 months. Children with severe comorbidity requiring pharmacotherapy, endocrine or genetic causes of obesity, deranged kidney function or jaundice, locomotor disability, and long-term medication including metformin and vitamin E intake were excluded from the study. So the sample size was calculated as follows. We assumed that proportion of children in the intervention arm would have a hepatic fat fraction reduction by 40%, which is based on few adult studies that have deemed this percentage as clinically significant on metformin. We assumed that proportion of children with hepatic fat fraction would be 12%, a power of 90%, two-sided alpha of 0.05, and an expected dropout rate of 20%. We estimated the sample size to be 120 with 60 participants in each arm. Because the study was conducted in the COVID-19 pandemic, the dropout rate was high and we had to enroll 140 subjects. Randomization was simple. Allocation concealment was with serially numbered opaque sealed envelopes, and both the investigator and the subject were masked to the assigned intervention. The randomization code was broken after the analysis of results. So this slide shows the baseline assessment that we undertook. So we assessed the hepatic fat content in these participants who were enrolled in the study with the help of MRI, which is next to the gold standard of histopathological evaluation. This was done using a 1.5 Tesla MRI machine and a fat quantity sequence software in a region of interest comprising the maximum area of axial section of the liver. Those with an HFF of less than 5% were excluded because they did not have fatty liver, and those with greater than 40% were also excluded because their disease severity was significant and they had to be referred to a gastroenterologist. We also did a detailed baseline assessment of dietary intake and physical activity in addition to body composition and various blood investigations related to metabolic syndrome. Liver fat and liver fibrosis were also assessed with the help of transient elastography. So there were two arms. The first arm was the intervention arm with diet, lifestyle, and metformin, and the second arm was control arm with diet and lifestyle only. So in the drug arm or in the placebo, the intervention arm, we had metformin and we had identical placebo tablets in the placebo arm. Metformin was started at a dose of 500 milligrams once daily and was increased all the way up to 1500 milligrams per day by month third of the trial. The diet intervention and the physical activity intervention were very rigorous and included individualized counseling and provision of diet charts, provision of healthy recipe booklets, dietary reinforcement, and group sessions, which were taken both in person and via virtual conferences, and rewards for efforts that children would put out. Physical activity intervention was also very rigorous. So this is the study flow. There were 391 patients who were assessed for eligibility, out of which 175 gave consent for hepatic fat fraction assessment. 140 subjects were eventually randomized to the intervention and control arms, and the final outcome assessment was done for 107 subjects. So as we can see in the baseline characteristics, the mean age was 12 years. We had about 1/5 of participants who were overweight and the remaining were obese. And the intervention arm and control arm had similar baseline characteristics. We see that for some of the other parameters as well here. Coming to the primary outcome, we see that subjects with a greater than or equal to 40% reduction in hepatic fat fraction achieved a proportion of 35% in the intervention arm and 39% in the placebo arm, and there was no statistically significant difference. We can also see in this graph that the baseline hepatic fat fraction reduced from 12% to 9% in the metformin arm at 6 months and from 12% to 7.8% in the placebo arm at 6 months. These differences individually were statistically significant, but when compared to one another, there was no difference between metformin and placebo. So metformin was not superior to placebo in causing a reduction in hepatic fat fraction. This table also shows group-wise paired comparison between the two groups for various other parameters. Highlighted in red are those which showed a statistically significant change, and these parameters, which were for both metformin and placebo, included weight, body mass index, body fat percentage, glycated hemoglobin, liver enzymes, and HDL cholesterol, and specifically for metformin included waist circumference and HOMA-IR in addition. It's interesting to note that the energy intake in both the arms was similar, and there was a statistically significant decline individually in both the arms as well, suggesting that dietary intervention was similar. This shows a change in parameters between both the groups, and we see that none of the parameters actually showed a statistically significant change. Change in B12 levels were also similar in both the arms. Compliance to metformin and placebo tablets was again similar in both the arms, and there were no significant adverse events reported in the study. So to conclude, metformin is not superior to placebo in reduction of hepatic fat. Statistically significant improvement in dietary modification was attained in both the arms. So hepatic fat reduction can be achieved by dietary and lifestyle modification alone. However, sincere and rigorous efforts are required by the treating physician, dietitian, child, and parents.
Dr. Sukanya, thank you for this presentation. I find your results very startling. There is just over 6 months of diet and counseling. We have shown a reduction in the hepatic fat fraction in both the groups by almost 40% or so. Such a huge reduction
Yes,
just over 6 months by diet and intervention, by diet and exercise alone. while the BMI impact on BMI is modest as expected, but there is a differential impact on hepatic fat fraction in both the arms. How do you explain that?
Ma'am, so when we had undertaken this study, the emphasis on diet and lifestyle was very much. We had trained dietitians in this study who made sure that the children followed up regularly, and even when they did not follow up physically, we interacted with them online. There was a specific WhatsApp group which had been created where the children were encouraged to put out the diet that they were having, the exercises that they were doing, and the ones who actually could come up with a good dietary change or a lifestyle change were also given rewards. So we ensured that diet and
I
lifestyle.
thought that the differential impact on BMI and hepatic fat fraction is what I wanted you to comment on.
Okay, ma'am. I do not have an exact answer to that at present.
Dr. Sukaya, I have a very quick question for you. Okay, so it's an interesting study, but in terms of the dosage of metformin, you are using the one tablet 500 milligram per day, and then 1,000 per day, until to the 1,500. Why not use to the utmost, like 2,000 milligram? Well, you only use like 1,500. You use 3 tablets to the largest dose, right? But you are not using 2,000 milligram of the metformin. Can you catch it?
These are more readily available preparations, more often used by patients who follow up that we were getting. So we initially chose to use this preparation of metformin, the 500 milligram tablets.
I have a question. Yeah, nice work. What was the rationale for using metformin?
So metformin has been seen, specifically in adult studies, it has been seen to show a reduction in liver fat content. This has also been seen in children as well, although the markers are primarily surrogate and not directly hepatic fat fraction assessment as we did in our study. And also from a pathophysiological standpoint, metformin use can justify reduction in hepatic fat for treatment of fatty liver.
I think any treatment we choose must be based on pathophysiology.
Yes, ma'am.
So what's the pathophysiology? And I would have guessed that metformin will do nothing actually.
So
yes, it's a lot of work you put in, so I could have told you that this wouldn't have happened, this would have happened. But the other issue is 40% reduction. What does it translate to in improvement of liver enzymes? 1%? 25%? What is the translation at that 40%? If adults have done it, it doesn't mean necessarily we should follow, because tomorrow I'll show you that there are quite differences between adolescents and adults.
Yes, ma'am. So the mechanism of metformin, wherein it acts to reduce hepatic lipogenesis and also address insulin resistance, have been hypothesized to justify its use in these studies of non-alcoholic fatty liver disease. And we do have pediatric data also, although most of these data are very conflicting. And again, in a very recent systematic review which was conducted on metformin use, it did not show any significant improvement. So this was a study we were concurrently doing at the same time just to assess. And the results of the study, in fact, highlight that metformin is not superior to diet and lifestyle intervention alone. And we must emphasize to our children that and their parents that this is the standard of therapy is primarily diet and lifestyle change.
I guess I don't have time for other questions, right?
A small question, and since everybody's after metformin, so it's just a small question for you. Generally, we start the metformin after breakfast. That is general dictum. But I saw that the first dose of metformin, or when the start of metformin was there, it was in the night. So was there any rationale behind it, or something else? And second thing was, did we use some sustained release tablets, or it was just a simple metformin?
Sir, so we did not use sustained release tablet. We had taken the simple plain metformin tablets only, the 500 milligram tablets. And I think that might have been, the metformin was started after breakfast itself, the first dose, OD dosing with after breakfast itself in these
It was
patients.
mentioned in the evening,
Yeah, I
so
think
that was the
so.
reason.
Yeah.
Okay, thank you.
Thank you. Okay, I congratulate all these speakers for nice presentation. So the announcement of award for this paper presentation will be announced. It will be announced tomorrow after the first plenary session, which is DSD symposium. Another thing is that one poster session has been started, and those who want to look at the posters may go there. Another session on automated insulin delivery system is going to start in Hall B101, Amaltas Hall. So those interested may go there. Also, lunch is going to start, so you all may join the lunch also. Now, I invite all the esteemed judges for the felicitation outside the hall. For this, I invite Dr. Vijayalakshmi Bhatia ma'am